From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today we're talking about habits that improve health. The authors of the Enhanced Lifestyles for Metabolic Syndrome, or ELM trial, focused on 4 simple habits: brisk walking, eating vegetables, paying attention to sensory input like smells and tastes, and emotional regulation, or pausing before stress eating. They designed a study that used behavioral science and peer support to build those habits, and they asked, can that be an effective and sustainable treatment for metabolic syndrome? So to talk with us today about this study, we're lucky to have Dr. Lynda Powell and Dr. Giselle Corbie. Dr. Powell is a professor in the Department of Family and Preventative Medicine at Rush University. She authored the study examining lifestyle interventions and metabolic syndrome, recently published in JAMA Internal Medicine. Welcome, Dr. Powell.
Thank you.
And to discuss this paper, I'm also thrilled to have Dr. Giselle Corbie, who's both my colleague as an associate editor at JAMA Internal Medicine and a professor of social medicine and medicine, director of the Center for Thriving Communities, and senior vice provost at the University of North Carolina at Chapel Hill. Welcome, Dr. Corbie.
Excited to be here.
Great. And Lynda, you are an expert in behavioral treatments to manage chronic diseases. So when you use that lens to look at treatment of metabolic syndrome, what gaps in the current treatment approaches did you set out to address?
We, on the behavioral medicine side, the behavioral sciences side, are frustrated. Why are we frustrated? Because of the check mark. So we call it the check mark. I'm not sure if you've heard of this before, but what it means is we can produce very short-term change, extreme short-term change on any lifestyle factor at all. And then gradually over time, people come back to the way they were before. So I have been doing lifestyle interventions for my entire career, and we just keep seeing the check mark over and over and over again. And it's not just people like me on the behavioral side who are frustrated, but I think the practitioners are frustrated. They try to get their patients to make changes in their lifestyle, and the patients just pop back. But also the patients are frustrated.
So then to address that issue, what did you do in the study?
So the basic science in behavioral science came out with a paper by Rothman, who said there are different strategies for initiating behavior than for sustaining behavior. So that was kind of new. We hadn't thought about that before. And then we started looking around for strategies to sustain behavior, because our interest is in producing a lifestyle change that's sustained over time. And we came across this habit modification stuff that was going on. It wasn't really popular, but it was going on. And it was all about figuring out ways to promote automatic habits, doing things that just were an automatic part of your routine as you go throughout the day. And we thought, wow, that's different from what we were doing before. Why not try that?
And what were your key findings once you worked on instilling those habits?
The first element is simplify the target.
Okay.
So when you think about physical activity, there are a gazillion ways of thinking about physical activity. We simplified the target and said daily brisk walks.
So not like a particular number of steps or a particular gym routine or something.
No, just the habit of going out and taking daily brisk walks. That was one of them. And then the other one that we simplified was eating vegetables at meals. So when you think about the diet literature, it's very complex and elaborate, all different kinds of ways of thinking about diet. We couldn't deal with that. We had to have something that was simple. So we just said vegetables at meals. And then the 2 mindfulness habits were all about trying to find a way to motivate people to do the second part of habit modification, which is you have to do it over and over and over and over again until it starts to become automatic. Until you don't think about it, you just do it. And we had to figure out a way to get people to repeat the habits for enough sessions so that it would become automatic. And so the mindfulness habits really helped us with this. And, this is not innovation on the part of our group. It's innovation from doing groups, experimental groups of participants, and they're telling us what works, right? And so what they said is, if I think about not what I want to do in the long term, but if I think about how I feel right now, how I feel eating vegetables, how I feel going out and taking a walk, how I feel when I notice breathing fresh air and the colors, it makes me feel happy and I want to do this more. And so the mindfulness habits are all about trying to get at the issue of motivation for people to keep doing it long enough before it became an automatic part of their daily routine.
It's so interesting disentangling. Like you usually think you motivate people by saying this is going to prevent a heart attack, this is going to prevent a stroke, in 20 years. But you're talking about something very different, which is being in the moment and that feedback.
Yeah, it's patient-centered. So I think what we're worrying about is that a lot of the motivation is practitioner-centered. We want to prevent people from developing a heart attack, moving into diabetes, et cetera, et cetera. And that's all from our perspective. When you think about what motivates patients, we're not getting a lot of feedback from them that is a motivator. What's a motivator is their quality of life and how they feel right now when they do it.
Oh, that's so interesting. Let's turn to Dr. Corbie now. I'm wondering, Giselle, if you can tell us what you were particularly struck by in this study. Was there parts of this that you found especially interesting?
Yeah, for me, it was the simplicity, the elegance and the simplicity of really bringing it to the point where it's doable, right? And it addresses environment, it addresses how people feel. And of course, the sustainability. We joked that we all have had that check mark, that we've all had that time where we were very motivated and we dug in terms of our lifestyle changes, exercise, diet, what have you, saw some improvement in our goals, moved towards our goals. And then over time, it just kind of erodes. And the fact that this intervention actually led to some traction there is exciting. The other thing that Lynda's talked about is the fact that the development of this was patient-centered and really focused on what people said were important to them and how it made them feel. And to me, that's a frame shift for me as a clinician also is how am I talking about lifestyle changes? I often talk with folks just about the automaticity, getting so that it's something that becomes a part of your life. But I also tell them it might take a little while for it to get there. And maybe I need to be focused on, well, you will feel better after X period of time once this becomes automatic for you.
That's such a nice thing to think about, the positive feedback right away, as opposed to the guilt about doing it wrong or the sense of like you're persevering through hardship by giving something up. This will actually feel good.
It's really switching from I have to do this to I want to do this.
Or I get to do this, right?
Right.
Yeah. That's one of my instructors talks about that. You get to work out.
Yeah.
It's a whole mindset change.
Great. One of the questions I had about this, though, is that the study had quite an intensive intervention and wrangled in a lot of components of interdisciplinary people and peer support. And I'm wondering if there are parts of it that you think are key or if there are other pieces that clinicians could take away, sort of clinical pearls that might not need all of the components of the intervention to succeed.
That's a great question, Eve. We are in the process of writing a paper on the basic components of the intervention, and it is going to be a per protocol paper. So I think that that's a step forward. But in terms of all of these different pieces of the intervention, which ones worked and which ones didn't, I am a champion of the simplicity of the goal and making it something that when people do it, they feel better right now. One of the things that I thought was kind of innovative, but an interesting approach was before we walked together, we're trying to get across the point that when you're physically active, you have an improvement in mood. Physical activity, it's got all these negative connotations, working on the treadmill, 80% of capacity, most days a week. People don't want to do that. People don't want to eat celery and lettuce. They don't want to enjoy life, And so what we're trying to do is disabuse them of the idea that living a healthy lifestyle is about deprivation and get across that this is really a way of enjoying life.
Are there next steps that you'd like to see in this field? Are there things that you want to know more about?
Absolutely. So first, I'll just touch on, as a clinician, the additional takeaways. The first, as we've talked about, is that simplicity, and actually that even education plus physical activity monitoring actually had some benefit over prior studies. So even in the comparator group, we saw gains above what we normally see. So if somebody's not interested in the other components, or as you think about those other components, that to me was really important to be able to bring to my patients. One of the things that I saw here is that motivation and assessing their motivation was key. This was a very highly motivated group to do the work, to even get into the study. I would love to understand, how can we think about getting people to that point of being highly motivated? Where's the gap between those that are highly motivated and those that are pre-contemplative? If you were thinking about theory of change, how do we get them to that point where they're really activated to be able to move the needle? I would also really want to understand more about cost effectiveness. In particular, with this kind of study, as we talked about, it's fairly intensive. The in-person sessions, even the online sessions were fairly intensive. Is there a role for AI in this, to be able to think about AI coaching around some of these issues? And I think that the elephant in the room are GLP-1 receptor agonists. What happens when we bring those together with this kind of change? Can we sustain the weight loss that we see on GLP-1s? Is that a way for us to flatten that check mark and keep it where, because we're seeing that GLP-1s, once you're off of them, you end up regaining the weight as well. So is there a space there that we can think about how can this augment, or how can GLP-1s augment where we are? How can we bring these two areas of science together to support our patients in terms of meeting their metabolic, clinical, and lifestyle goals?
You've asked two really important questions that I don't want to forget that you asked. One is the issue of trying to motivate people who may not be motivated to change their lifestyle. So I think we have to respect our patients more. So as we were screening people, we started casually asking them, if you have the metabolic syndrome, how would you like to manage it? And we came out with a 40-40-20. 40% said, I just want to use the drugs that my provider gives me. Another 40% said, I don't want to be on drugs. I want to try lifestyle. And another 20% said, I don't want anything. I don't want to have my doctor tell me to do something. I don't want you. I'm just happy the way I am, And I think that the reason we really focused on finding patients that were motivated in this trial is because we were trying not to get into the situation that I've been in so many times before, where we do a hard sell.
Mm-hmm.
We're doing a lifestyle intervention, doing a hard sell on our patients. Oh, this is the greatest thing in the world. You're going to love it. And what happens is we convince them. And then ultimately they vote with their feet and drop out because this is not what they wanted. And so what we were trying to do is say, okay, not everybody loves us. Let's find the group that would potentially really benefit, the group that's most closely aligned with the treatment that we're offering. So it's kind of like precision lifestyle medicine. And so that's why we did what we did, because we're trying to acknowledge that there are many people who have the problem, but who just don't love us. And therefore, let's try to find the ones that do.
Well, the other thing is really understanding the mechanism, because I actually was really interested in the idea of emotional regulation, the emotional piece of this, sort of the mindfulness and emotional regulation. And actually, the emotional regulation really didn't change that much at all in the study, which was disappointing to me, because that to me sort of signals a potential causal pathway. And so I still want to understand a little bit more about mechanism here. And then the bottom line here is that the field really needs to move away from does lifestyle intervention work to what specific approaches for which patients work and how do we implement them in a real world setting. That's what I saw from this. And I was really excited about the findings. And it also raised so many more questions in terms of where we can go with this work.
By the way, my vision, my hope is that we will be able to take a next step and do a combination of the obesity drugs with the lifestyle intervention, because the obesity drugs work as long as people are taking them, and our lifestyle intervention works after the intervention is over. So they are a perfect marriage. And so that is my vision. We're ripe for that.
Yeah, it's the moment. I'm glad you're going to be doing that work.
Thank you so much. I will encourage our listeners to take a look at the published study for more details on what was involved. So thank you both very much. I'm Dr. Eve Rittenberg, and I've been speaking with Dr. Lynda Powell and Dr. Giselle Corbie about behavioral interventions to treat metabolic syndrome. You can find a link to the articles we discussed in this episode's description. The episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.